Good evening. My name is Nisi Johnson with the Association of Black Cardiologists. I thank you for joining us tonight with our Spirit of the Heart event for Little Rock. A couple of housekeeping notes to bring to mind before we begin tonight's session. First, I would like you to know that this event is being recorded for future use on the ABC's website and other media platforms. Secondly, we are also streaming live on Facebook. So do invite your friends and families to join us. Finally, and most importantly, on the bottom of your screen, you will see a Q&A button. If you have questions during tonight's event, we invite you to post your questions there, and either one of our clinicians or one of our distinguished panelists will be able to address your question. So with that, I invite you to enjoy this evening's session. And now I invite you to welcome our co-host, Dr. Joe Hargrove from Little Rock. Dr. Hargrove.
Thank you very much. Good evening, everyone, and welcome to this Spirit of the Heart Leaders Forum for Little Rock, hosted by the Association of Black Cardiologists Incorporated, by CHI Heart Clinic Arkansas Cardiology and Medicine Clinic, and the Office of the Mayor of Little Rock, along with our many partners and supporters. My name is Joe Hargrove. I'm an interventional cardiologist and a partner with CHI Heart Clinic Arkansas Cardiology and Medicine Clinic. As a longtime member of the Little Rock community and the first Black cardiologist to practice in Arkansas, I have seen firsthand the devastating impact that heart disease and health disparities has had on our community. We are here tonight to bring awareness about heart disease, stroke, high blood pressure, diabetes, and the other cardiovascular risk factors to our community, so that we can begin to take actions to address the deaths that our community experiences yearly from this preventable condition. 80% of heart disease is preventable. We are approaching a third year dealing with COVID-19 and the devastation it has had on our community. We've had a large number of people to die in Arkansas from COVID. And while it is important to continue to recognize the risk COVID has made, we need to make sure that our population is vaccinated. We must still pay attention to the number one killer of individuals in Arkansas, as well as the United States as a whole, and that is heart disease. So I would like to thank each of you for joining the community forum tonight. In addition, I also want to extend a special thanks to the forum planning team, volunteers, and our sponsors. Programs such as this could not be successful without the continued support of our partners. Before we begin this great program, I would like to open with a prayer from my bishop, Bishop Steve Arnold from Grace Temple Church.
Lord, we do thank you for this day. We thank you, Lord, for this glorious opportunity to gather together. We thank you, Lord, for this forum. And Lord, we pray even now for our country, our city, and our communities. We pray, God, that through this event that you would continue to give us the information as well as the inspiration to be better informed about our overall health and our overall well-being. And Lord, we come now praying for this forum that it may continue to bless us and give us the information that we need to take better care of ourselves. And once again, Lord, we lift up our country, our city, and our communities. Bless this webinar like only you can. In your son's name we pray, amen.
Thank you, Bishop. Now I would like to introduce Dr. Paul Underwood, a past president of the Association of Black Cardiologists Incorporated, and the co-chairperson of the Community Programs Committee of ABC, to provide an overview of the Association of Black Cardiologists and the Spirit of Heart programs. Following Dr. Underwood, we would have our mayor, Frank Scott, followed by Chad Adoodle from Common Spirit.
Thank you, Dr. Hargrove, and good evening. First, I want to thank you all for attending and welcome you to the Association of Black Cardiologists Little Rock Spirit of the Heart Community Leaders Forum. I am Paul Underwood, an interventional cardiologist and co-chair of the ABC's Community Programs Committee. On behalf of the association, I want to graciously thank Doctors Joe Hargrove and Anthony Fletcher for assembling tonight's fantastic event. I've really been looking forward to it. I'm engaged with ABC for 3 reasons. Number one, as a child on the heels of the civil rights movement, I understand the fight for justice in America continues, and this is my vehicle for social justice. Number two, I'm a doctor with a lifelong commitment to reduce suffering and premature death. And number 3, I've spent most of my career working to improve healthcare in disadvantaged communities. I was blessed as a student at Morehouse to have met Dr. David Satcher, and he deeply instilled in me at an early age to be an advocate for our community's health. The ABC mission is to eliminate disparities related to cardiovascular disease for all people of color. And we adhere to the vision that all people, regardless of race, ethnicity, or gender, should benefit equally from a reduction in the frequency, duration, and impact of diseases of the heart and blood vessels. Since our founding in 1974, ABC has focused on building strong, effective relationships with stakeholders throughout the healthcare community to help advance our mission. We realize, and we want all people to be made aware, that heart disease is the leading cause of death in the African American community. We are steadfast in our resolve to direct attention and resources to reduce the burden of cardiovascular disease on the Black community, so all Americans can enjoy the benefits of good health on their life and well-being. As I'm sure we'll learn later tonight, heart disease is multifactorial. It includes stroke, heart failure, heart attacks, sudden death, aneurysms, and amputations, but it also includes hypertension, diabetes, high cholesterol, and many lifestyle risk factors. Just as heart disease is multifactorial, it will take a multifaceted approach to eliminate the systemic and intrinsic barriers to us living our full, healthy lives. The ABC stands on 5 pillars to eliminate the gap between Blacks and other Americans with heart disease. We are dedicated to broadening the understanding of heart disease in African Americans and what can be done to lower the impact on our community. The first pillar is community. ABC started community intervention in Baltimore in the mid-1970s. We were the first to use barbershops and churches as hypertension screening and cardiovascular wellness centers, and this tactic remains a very effective method for disseminating life-saving education to our community, particularly those at highest risk, young Black men. Over the past 50 years, the ABC network has grown in its ability to provide education and stimulate action to control heart disease, particularly in African American communities. This Spirit of the Heart event is a culmination of what we've learned from projects like Heart Health for Generations, Children Should Know Their Grandparents, Choices, Before You Eat the Church Food, Not in Mama's Kitchen, and Super Weekends. We also have many online resources, and I encourage you to visit our website to browse what's available. The Community Programs Committee currently is paying attention to its CHAT, our Community Health Advocate Training Project. The ABC firmly believes there is no reason for disparity in health outcomes to exist, and these disparities can be eliminated, but it will require a lot of work on multiple fronts. The ABC is a very collaborative organization, and the staff is fantastic. Many thanks to Nisi Johnson, Uzoma Nukaberry, Donnell Ivy, Antoinette Birch, and of course, Alan Merritt, our Master of Technology. Through advocacy, our second pillar, ABC communicates what we've learned and experienced in the community by using scientific research to inform stakeholders, policymakers, and regulators that impact our health. The key areas of ABC policy and engagement are Black maternal health, health equity, access to treatment, clinical trial diversity, Medicare physician payment, and prevention. Our advocacy committee works closely with our community programs and women and children's committees. Through our network of medical societies and health advocacy agencies, we promote legislation and oversight to protect the health of our people. We're currently battling against menthol cigarettes. We hosted an Expand Your Impact through advocacy training for our chat groups in Jackson and New Orleans. We had a membership call to action and wrote a letter to the FDA requesting they eliminate menthol flavoring from tobacco products, basically as they have done for all other flavored tobaccos already. The medical education and research pillar provides us data that supports the elimination of disparities. The ABC is a leader in providing accredited CME training for physicians, particularly African-American physicians. We have an online platform, but most of our work is done during major medical society meetings like the NMA, American Heart Association, or the American College of Cardiology. During these sessions, leading experts discuss the latest data on cardiovascular disease and its impact on people of color. Research is important to know how treatments can benefit the most people. It is very important to know how the medicines you take work in people like you. The ABC promotes more engagement from the Black community to have a hand in developing the therapies that are used to treat our patients. Access to these therapies is another very important factor that ABC brings to the forefront. ABC relies on members like Doctors Hargrove and Fletcher to accomplish its mission. We all work together, but to be clear, the bulk of ABC's membership are not cardiologists. ABC membership is open to anyone. Our largest contingent are community advocates. Also, you don't have to be Black to join ABC. ABC membership is open to anyone that wants to see a reduction of heart disease, understanding that Blacks in America have faced tremendous obstacles to receiving quality healthcare, and direct action must be taken to bring us to parity. The ABC is very committed to its membership. We're very concerned with the pipeline of African-American cardiologists, and we actively engage cardiologists in training with education, camaraderie, mentorship, and scholarships. For members out of training, ABC promotes their work through speaking engagements, committee appointments, research studies, you name it. There are many, many different ways that our talents and everyone's talents can be put to work. ABC members are involved in industry, academia, government, and of course, clinical care. In fact, one of the leaders of research in our country, the head of the National Heart, Lung, and Blood Institute, is an ABC member. The ABC welcomes your input and the time, talent, or treasure that you can assist our mission with. There's a lot to be done. Thank you for your time and your participation. I'll now hand the show back over to Dr. Hargrove. Thank you.
Thanks very much, Dr. Underwood, for that massive amount of information. We will now hear from our mayor, the mayor of our great city of Little Rock, Mayor Frank Scott Jr. Mayor, would you please give a brief background?
Thank you so much, Dr. Hargrove, and to all of the members of the cardiologist community and healthcare community within the city of Little Rock. It is indeed a pleasure to be a part of the Spirit of the Heart. One of the things I want to take time to address is how COVID-19 has played a vital impact on health equity, as well as healthcare policy from a city perspective here in the city of Little Rock. I can tell everyone when I took my oath of office on January 1st of 2019, I would have never expected to lead through a global pandemic, lead through the summer of George Floyd that eerily reminds us of the summers of the 1960s, or to experience climate change as it relates to historic floods and snowstorms in Arkansas state capital city. And when we experienced COVID-19 as a global pandemic within the state's capital city, I can assure you that I am not a medical professional by any stretch of the imagination. But as a leader, it is my job to hone in and lead as it relates to the public health, safety, and welfare of the residents of the city of Little Rock. When we encountered COVID-19 as it relates on March 11, 2020, as we all know here in Little Rock, it changed our lives forever. We are living history since there's not been a pandemic since 1918, and we had to lead through that. We had to call upon countless medical professionals, medical doctors, medical leaders like Dr. Hargrove, Dr. Bedden, Dr. Fletcher, Dr. Kershell Nash, who are all here, many members of the AMDPA community, Chad Adodo, who's the Common Spirit CEO here in the city of Little Rock, all played a role in advising my administration through this pandemic. One of the things that we know as it relates to Black men and women, and not only in Little Rock and Arkansas, the pandemic unmasked existing healthcare disparities as it exacerbated those healthcare disparities, whether it be heart disease, whether it be countless other disparities that we experienced that were exacerbated as a result of the pandemic. And so we had to make drastic decisions to not only protect the residents, but prevent COVID-19 from truly being a costly epidemic than it already was. And so I want to take this time to share our appreciation to Dr. Hargrove, and countless others of the AMDPA community, our COVID-19 healthcare task force, as we led through that. Secondly, as we go through that process, many times we had to understand the data-driven decisions based off of policy to decide whether or not to reduce gatherings. At one point, we all know there was recommendations and regulations on gatherings from 500 people. The next week would be 200 people, all the way down to at least 0 for a period of time. We had to shutter, unfortunately, restaurants from in-person dining. We had to make very drastic decisions, even masking. And we see that we've had more than one phase of COVID-19. And when we talk through this process, and I share this from a policy perspective of how vital it is to have medical professionals involved, engaged in not only the political process, but true servant leadership and public service. Because Little Rock would not be a growing city without the advice of the AMDPA community, without the advice of Dr. Hargrove and countless others that advised our administration on how we led through this process, which helped us to still be one of the 2 cities, mid-sized cities within the South to grow during that period in time. And it's because Little Rock is a healthcare epicenter. Little Rock has the only graduate medical education institution within the state of Arkansas. And that's how vital role it plays in the role of politics and public policy. More specifically, we have to continue to focus on health equity. We know that many minority communities are plagued with healthcare disparities and sometimes lack of access to true healthcare. And so that's the reason why we have to continue to have this nexus between public policy and healthcare. And so we want to take this time to share not only what we were able to do to get out of the pandemic, but how we're now focusing on greater determinants of healthcare disparities to truly have public policy as we're forming a new transitioning from our COVID-19 healthcare task force to a health disparities commission that we are working on right now, and how we have to continue to have more doctors and medical professionals involved in the public process, in the public square, to move our cities forward, because we all know the nexus between economic development and education is healthcare. Healthcare sustains our workforce. Healthcare sustains our families. Healthcare sustains the forward movement of our cities as we move forward together. And so I want to just take this time to share appreciation to our medical community, share appreciation to the American Black cardiologists and what they do nationally, but particularly what's going on here in the city of Little Rock as we continue to move forward together. I want to take this time to say thank you and understand again the great nexus between healthcare, economic development, and education. Thank you so much.
Thank you very much, Mayor Stott, for those encouraging comments. Next, we'll hear from Chad Adul. And Chad, would you give a brief background?
Thank you, Dr. Hargrove. So grateful to be with ABC, the panelists tonight, the audience that's listening in. Just humbled and blessed to be with you all. I'm gonna give Dr. Hargrove just a little bit of a hard time. My name is Chad Adul. And the reason I'm gonna joke about that is it's my grandmother's favorite story, our last name. And so when I was in kindergarten and graduating to go to first grade, they had a little ceremony and brought us up on stage and gave us a certificate. And of course, with a last name that begins with A, I was the first one called up on stage, and the principal mispronounced the last name, and I shook my fist at her. So for the last 50 years, my grandmother has given me a hard time about that event. And so I've become much more flexible and humble about people pronouncing such a difficult last name. So I would never shake my fist at Dr. Hargrove, but in all kidding aside, thank you, Dr. Hargrove, Dr. Fletcher, Mayor Scott, for allowing us at Common Spirit to join you tonight and participate in the Spirit of the Heart and such important work that we are doing and that needs to continue to be done in the community. So I look forward to being part of the panelists this evening.
Thank you very much, Chad. We're here today to discuss and address the ongoing challenges of heart disease in our community. It is now time to turn this over to Dr. Anthony Fletcher, my partner at CHI Heart Clinic, Arkansas, Cardiology and Medicine Clinic, who will give a brief overview of cardiovascular disease and the ABC's 7 steps to a healthy heart. Dr. Fletcher is the first fellowship-trained interventional cardiologist to practice in Arkansas, and he joined Cardiology and Medicine Clinic, my practice, in 1986. So, Dr. Fletcher.
Thank you, partner. It's always a pleasure. First of all, I'd like to thank everyone for participating this evening, and Mayor Scott and Chad. We always call you Chad. I don't think any of us had heard your first name before we started talking about this program. So we welcome your comments, and we appreciate you participating. Now, cardiovascular disease in Afro-Americans is certainly something that's very dear to my heart and my professional career. I have no disclosures as far as professional or commercial interest here. But cardiovascular disease in Afro-Americans is being addressed across the country, and the American Heart Association, along with the Association of Black Cardiologists, has always been a forefront in terms of giving us information. But data collected has shown us that life expectancy of Afro-Americans was 3.4 years shorter than our Caucasian counterparts. That average age being 75.5 years for Afro-Americans versus 78.9 years for our Caucasian counterparts. And that's certainly an important statistic. Both sudden cardiac death and cardiac arrest are higher in Afro-Americans as compared to Caucasians. And hypertension is 10 to 12% higher in Afro-Americans than in non-Hispanic whites and our Mexican-American colleagues. Diabetes, obesity, and chronic kidney disease are more common in Afro-Americans, and very importantly, often in a very young age. And this plays a role because when we get older, our morbidity and mortality with acquired disease entities is much higher, as recently evident by the COVID-19 pandemic. Disproportionately, Afro-Americans were more likely to end up on ventilators and to succumb to COVID because of their underlying chronic conditions. The American Heart Association also tells us that barriers to reduction in these disparities include education regarding nutrition and disease prevention in the young, and early detection and intervention is very important in our ability to move forward. Next slide, please. As mentioned earlier, just an overview, heart disease in the United States is the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. One person dies every 36 seconds in the United States from cardiovascular disease, and about 655,000 Americans die from heart disease each year. That's 1 in every 4 deaths. Our disease has a tremendous financial impact on our federal government, our state government, our local governments, costing about $219 billion a year. This cost includes healthcare services, medications, and loss of productivity due to death. Next slide, please. Let's talk a little bit about what is cardiovascular disease. You hear that term. And so coronary heart disease is certainly the most common at 45.1% of the deaths. And coronary heart disease is comprised of myocardial infarctions or heart attacks, angina pectoris in terms of chest pain coming from lack of circulation to the heart. Stroke, 16.5%. Stroke is damage to the heart because of death, because of lack of blood flow, either from occlusion or hemorrhage from bleeding. Heart failure, which is an increasing component of cardiovascular disease, is the lack of heart to meet the demands of the body, either because the pump has been damaged or because the heart is stiffened and it has decreased ability to fill, therefore affecting the ability for the heart to be a passive pump. High blood pressure, again, epidemic in the Afro-American community, but that comprises 9.1% of the deaths that we see. Disease of the arteries is a composite of aortic dissections, aneurysms, and other diseases of the aorta that might result in inflammatory changes that have occurred. Others include valvular heart disease, arrhythmias, and a growing number of people have peripheral vascular disease, which might also be considered into the arterial disease component. Next slide, please. Black Americans and heart disease. Again, this slide is to just show us that Afro-American men and women unfortunately have a greater prevalence of death from cardiovascular disease compared to any other minority group or majority group that exists in this country. Next slide, please. Again, this slide is to depict data again from American Heart Association via circulation. The disparity in deaths, the top curve in red represents the deaths in Afro-Americans. Even though we see those numbers are decreasing, the number is still significantly higher than Caucasians, than Asian and Pacific Islanders and Hispanic individuals, as well as our Native American, our Indian population. Next slide. Risk factors, and that's one of the reasons we're here tonight, to talk about what we can do to help prevent heart disease. There are two categories of risk factors. One are factors that we can't control: gender, heredity, and age. We cannot control those. But the factors that we can control are consistent with being over ideal weight, high lipids or high cholesterol numbers, high pressure or hypertension, high blood sugar or diabetes, and smoking. And smoking is probably the number one modifiable risk factor. Next slide, please. Again, we look at risk factors, and to delve into those just briefly, smoking is a strong risk factor for all forms of cardiovascular disease. And Afro-Americans have a greater tendency, as mentioned earlier, to use the menthol-containing products just because of the taste, and that is a more addictive component of cigarettes. We also are exposed to more secondhand smoke because of being in smoking environments or our work environments. And unfortunately, we're less likely to quit. The next modifiable risk factor is obesity. Afro-Americans have the highest rate of obesity. 1 in 5 children are obese, which again sets up the whole propensity for further future issues with diabetes, hypertension, and other disorders. Hypertension, again, a most potent risk factor for CVD in Afro-Americans. And as mentioned before, it is sort of an epidemic in our community. Diabetes mellitus is more common in Afro-Americans and is increasing in prevalence as we become more obese as time goes on. And it's more likely to have us sustain complications such as diabetic retinopathy and end-stage renal disease. Lipid disorders, again, we're less likely to be aware that we have elevated cholesterol. We're less likely to get treated, less likely to be treated to goal being that you're treated to a level where it's no longer as much of a risk factor. And guideline recommended treatments are underutilized in all ethnic groups, Afro-Americans included. Next slide, please. Inactivity, again, we as a race of people are less active to participate in exercise. The recommendation being 150 minutes of a moderate to intense exercise per week, or 75 minutes of intense exercise per week. And again, unfortunately, we are less likely to participate. And finally, family history. That is a significant risk factor. And as mentioned earlier, children should know their grandparents and become grandparents themselves. Next slide. Again, this slide is just to quickly depict how additive risk factors are. Smoking is a very high risk factor by itself, but when you add diabetes, hypertension, elevated cholesterol levels, the more of those you have, the higher risk you have for myocardial infarctions and cardiovascular disease. Next slide, please. And so the ABC years ago came out with 7 steps to a healthy heart: access to better health care, take charge of your blood pressure, control your cholesterol, track your blood sugar, don't use tobacco, eat smart, and enjoy regular exercise, and of course, be spiritually active and reduce stress. And so those are sort of the quick synopsis of cardiovascular disease and the 7 steps that ABC recommends. Addressing heart disease and reducing disparities is important to all of us in Arkansas. We're here to make changes necessary to reduce death from heart disease, and then we need to work together on solutions to help solve problems. But how big is the problem of cardiovascular disease and health issues in Little Rock and in Arkansas? Our next speaker, Dr. William Greenfield, will provide us with the current state of health in Arkansas. Give you a brief introduction for Dr. William Greenfield. Dr. Greenfield is a fellow of the American College of Obstetrics and Gynecology. He's medical director of family health at the Arkansas Department of Health. And during that time, during the pandemic, he has been an outspoken advocate for minorities and our needs in the pandemic, and as well as keeping us abreast as to the current progression and recommendations that were set forth by the CDC and the state government. He's received his Bachelor of Science degree in pharmacology from Auburn University. He's a Doctor of Medicine from Meharry Medical College and completed his residency in OBGYN at the University of Arkansas for Medical Sciences. Dr. Greenfield is a dedicated professional focusing on improving healthcare through clinical excellence, education, and advocacy and innovation. He lives here in Little Rock with his wife, Tiffany, and 3 children, Alexandria, Pearson, and Victoria. And to share a personal note, Dr. Greenfield, over the course of time that I've known him, has been a gentleman, a scholar, and certainly is a person who certainly exhibits the use of the art of medicine as well as the science of medicine. Without further delay, I'm gifted to give you Dr. William Greenfield.
Dr. Fletcher, thank you very much for that very kind introduction. Since 2020, much of the public discussion has revolved around COVID-19, and deservedly so, as is alluded to earlier, with the impact of the pandemic on the community. But death, dying, morbidity, mortality did not stop. And there were other big health problems that we have faced and we continue to face. So I want to thank ABC for this forum addressing cardiovascular disease and particularly its impact on Arkansans. When we look at Arkansas, the question is, what's the state of Arkansas? We have 75 counties in our state. Over 3 million people live in Arkansas. And children under the age of 18 make up about 23% of the population. People over the age of 65 make up about 17% of the population. African Americans are about 15% of the overall population. When we look at our counties, as I said, 75 counties exist. The number of people in each county has changed over the past several years. Some counties in central and northwest Arkansas have increased, and then in some counties, the number has decreased. But Arkansas overall is a very rural state. Only 19% of the people in the United States live in rural areas as compared to 44% in Arkansas. The Department of Health conducts an annual phone survey where we reach out to ask individuals, how would you report your health? In the state of Arkansas, 14% report excellent health, 29% report very good health, 32% report good health, and then 17% and 8% respectively report fair and poor health. So that's about 25%, about 1 in 4 reporting either fair or poor health. So a sort of a self-assessment of where we are, people indicate that they don't feel that their health is very good. Life expectancy in Arkansas reflects and supports what we're discussing. I want to explain the map that you're looking at. This is a map of counties in the state of Arkansas, and you can see what the life expectancy is in Arkansas by county. The counties that are white, the counties that are color white, and there's only one in the state, those are the counties that have a life expectancy that exceeds that of the US life expectancy. That's up in Benton County. In 2016, the average life expectancy for Arkansas was 75.8 years, which is about 3 years shorter than US life expectancy. The red and white counties, those are 74 to 80 years, and those counties that are in red are counties that have a life expectancy of less than 74. Monroe County has the shortest life expectancy at about 70.6 years. So what are our main causes of death? In 2018, heart disease, cancer, chronic lung disease, so on, through the top 10 that you can read here. The leading cause of death in Arkansas is listed, but the impact of cardiovascular disease is seen throughout this list, with heart disease, with stroke, with diabetes, with kidney disease. So the presence of severe morbidity impacting our population persists. Arkansas and the United States heart disease mortality rates for the years 2009 through 2018, you can see that consistently and persistently Arkansas exceeded the heart disease mortality rates for the United States. And to explain the map as we go forward, to explain the table, this is adjusted to a rate of per 100,000 population so that we can make sure that we're doing an apples to apples comparison when we look at our numbers from a small state and compare them to those of a larger state. If you look at Arkansas heart disease mortality rates by race and sex between the years 2009 to 2018, we see that green and blue at the top represent Black men and white men respectively. The yellow and the purple represent Black women and white women respectively. And Black men consistently and persistently are suffering and show a higher degrees of heart disease mortality than Black men. Black men are higher than white men, and Black women have shown a higher disease mortality compared to that of white women. So this is supporting the fact that the disparity has been there. Though we have seen some improvement, time will only tell if this was an anomaly for 1 year, but hopefully that we will narrow these gaps as the years continue. Arkansas U.S. stroke mortality rates. We've seen that Arkansas, again, though we've had a decline in a narrowing between the Arkansas's rate and the United States rate, we suffer from a higher degrees of stroke mortality as compared to the country at large. And if you were to look at our stroke mortality by race and sex, similar to with the heart disease, we see that Black men have the highest rate mortality of all the groups that are listed. The impact of cardiovascular disease on hospitalizations. Now, the table that you're looking at now shows heart failure, which shows cardiac dysrhythmias. It shows hypertension with complications secondary to hypertension, cerebral infarction, and acute hemorrhagic stroke, all cardiovascular disease hospitalizations from 2016 to 2019. And you can see that heart failure is leading the way, followed by cardiac dysrhythmias, as well as MI, and then followed by cerebral infarction. If you were to look at the cost, and I think this is a very important slide because this is a charge on our resources as a nation, as a state, and as a city. Myocardial infarction sits at the top in terms of costs in millions of dollars, followed by heart failure, followed by cardiac dysrhythmia. So there's a significant impact on the cost of to our society as a result of cardiovascular disease. And when we look at cardiovascular disease age-adjusted mortality from Arkansas for the years 2016 to 2020, again, you can see that ischemic heart disease is leading the way, followed by acute myocardial infarction, as well as other cardiovascular diseases. If you were to look at hospital discharge information and hospital discharge data for the years 2016-18, you can see that the numbers have held steady over the past several years, with heart failure again leading the way. And lastly, if you were to look at the prevalence of atrial fibrillation, heart failure, ischemic heart disease, and stroke, you can see that unfortunately Arkansas has a dubious distinction of exceeding the US average prevalence. So all of these represent challenges and opportunities for improvement. I would like to direct you to the State Health Assessment 2020, Arkansas's Big Health Problems, which was the source of most of the information that you've seen presented. If you show your mobile camera at the QR code, you can pull this report and it may help guide you as you make decisions and recommendations going forward. Thank you.
Thank you very much, Dr. Greenfield, for a very informative presentation about the burden of heart disease in Little Rock in the state of Arkansas. Action is needed to reverse those trends and improve the health of our community. There are steps we can take, and hopefully our panel discussion will enlighten us on some of the initiatives that can be taken to improve our overall health. Dr. Chriselle Nash will moderate our panel. Briefly, Dr. Nash is the Medical Director for Health and Equity and Public Programs at Arkansas Blue Cross Blue Shield. And in that role, she provides leadership for developing, implementing, and evaluating health equity initiatives to help create a more inclusive and non-discriminatory healthcare system throughout Arkansas. In addition, in that role, Dr. Nash serves as a consultant for community engagement and social determinants for the health and equity at the University of Arkansas College of Public Health. She receives her medical degree from Maryland School of Medicine in Baltimore, a residency in internal medicine from Washington University Hospital in Washington, D.C., and a master's in public health from Harvard University School of Public Health, and a fellowship in minority health policy from Harvard University School of Public Health. Dr. Nash.
Thank you. Thank you, Dr. Hargrove. Let me add my welcome and good evening to our participants and to this important conversation today. I'm excited to be here with you to move this discussion forward and to be the moderator of our panel this evening. My purpose here is to increase the awareness and conversation around the action, what we can do. We've had a lot of information already from Dr. Fletcher, Dr. Greenfield, and they will remain with us, as well as Mr. Aduddle, got it right, as a part of the panel. We want to understand this data, so I'm sure you have many, many questions. So please, I will remind the audience to put your questions in the Q&A section of your Zoom, and we will try to get to as many questions as we possibly can. I have the honor of introducing our additional panelists this evening, and I will call them one at a time so that you can know who's around the virtual table with us, so that you can ask questions and hopefully to increase awareness, not only about what they are doing, but what we can do together. And so again, for us to have a robust discussion and a discussion that moves us to action, please put your questions in the chat. So I'll first begin with brief introduction. Please, as I call your name, introduce yourself and or your organization. Let's start with Kenya Eddings.
Good evening. My name is Kenya Eddings, and I am the director of the Arkansas Minority Health Commission. The Arkansas Minority Health Commission was created a little more than 30 years ago by former U.S. Surgeon General, Dr. Joycelyn Elders, for the purpose of creating equitable access to healthcare to Arkansas's minority population. We further that mission by providing health education and providing access to preventative screening so that we can reduce and or prevent chronic diseases that affect minorities in the state. Chronic diseases like cardiovascular disease, which is what we're talking about this evening. So excited and honored to be here to join in this discussion.
Thank you. Thank you. Next, Reverend Slater, please.
My name is James Slater. I'm pastor of the Mount Pleasant Missionary Baptist Church in Little Rock, Arkansas. We are members of the Union District Baptist Association of Little Rock. And I add that because the Union District is an organization where a number of churches partner across ministry dealing with issues such as what we're talking about tonight. It is an excellent vehicle to get this information into their hands. Many of our churches already have such programs going, but certainly the information that we're seeing here tonight, we can do a whole lot more. So that would be an excellent resource. Thank you.
Thank you. Patricia Brown.
She wasn't able to join us today, so we can.
Okay, thank you. Dwight Flanagan.
Yes, good evening. Can you hear me?
Yes, we can.
Okay. My name is Dwight Flanagan. I've been an RN for 23 years. I'm with Grace Temple Church under Stephen Arnold, and we have established a health ministry. Hadn't done much post-pandemic, but that's going to change after this panel discussion. I appreciate being here. I appreciate being invited, and I appreciate being among such distinguished panelists. Thank you.
Thank you, sir. Mr. William Tolles.
Thank you. Yes, my name is William Tolles. I'm a retired investigator from the Department of Human Services. And I'm serving as the patient representative on this. I just want to say I'm happy to be here.
Thank you. Thank you for joining us. Your voice is critically important in this discussion. And as I stated earlier, Mr. A. Duddle and Dr. Fletcher and Dr. Greenfield are remaining with us. So I want to thank the panel for joining us this evening for what I hope will be a very important and informative discussion. So again, I'll remind our participants, please put your questions in the chat, but I'll take the moderator privilege if you don't mind, and I will start the discussion. And I'll start with Mr. A. Duddle. Can you talk a little bit more about, you mentioned Common Spirit. What are you doing to address health disparities and cardiovascular disease in Little Rock?
Well, thank you for the question. And to really answer that question, I need to give just a little bit of background on who Common Spirit is. Common Spirit Health is the parent organization for St. Vincent. St. Vincent is the name you know here in Little Rock. A ministry began by the Sisters of Charity of Nazareth humbly over 130 years ago, back in 1888. And it's important to know what our mission is, who we serve. Our mission at Common Spirit Health at St. Vincent is to make the healing presence of God known in our world by improving the health of the people we serve, especially those who are vulnerable, while we advance social justice for all. Now, these 35 words are a declaration of why we exist. Our vision, a healthier future for all, inspired by faith, by innovation, and powered by our humanity. And so how does that mission and vision, to your question, become brought to life in our community? How does it manifest itself? A little bit about who we serve. So every day that ministry is brought to life by those in the neighborhood around us. 42% of the households within 5 miles of St. Vincent Infirmary are African American, and 65% of the patients treated at the infirmary from our top 3 zip codes are African American. So the African American community is a significant part of who our ministry at St. Vincent serves every day. What are some of the community education efforts that we are out there in the community providing to increase education and awareness about cardiovascular disease? And I was think about some of the ABC's 7 steps that were mentioned by an earlier panelist. We have to be aware of blood pressure. We have to take control of blood pressure. So what are some ways that we're doing that in the community? Well, we've installed community kiosks at the North Little Rock Mall and at the Park Plaza Mall here in Little Rock, and we have an additional one coming in Hot Springs as well. And those kiosks are there to monitor blood pressure, and we have thousands of people that utilize those kiosks. And the data that we receive from that tells us that 50% of those that are participating in those kiosk blood pressure checks are from the African American community. We take that data, we're able to reach out and then connect to those community members with their blood pressure results, educate them about those blood pressure results, and then try to engage them in their own healthcare related to their risk factors and those results. So those are just a couple of simple ways that we're increasing awareness and access. We're also doing what Dr. Underwood talked about. We're relying upon some of those strategies that have worked for decades, whether it's reaching out to the African American community through the churches or through the barbershops. And those have been some key strategies and initiatives to increase access, increase awareness to the African American community about blood pressure screenings, about free HeartSmart heart screenings to their congregations, and then making discounted heart screenings available and programs available through that barbershop program. And then, of course, partnering and increasing awareness through local radio stations, The Box, Broadway Joe, running live interviews with Doctors Hargrove and Fletcher to educate the audience on heart health. And then we're also reaching out through the Little Rock Air Force Base.
Wonderful. Sounds like you're doing a lot of different things. Thank you. Thank you for that overview. And we're starting to get questions from the chat. So I'll take one more privilege and then I'll start asking questions from the Q&A section. Dr. Fletcher, you and Dr. Hargrove have been pillars of the community for a very long time and partners in the heart clinic. Can you talk about what your clinic is doing to address cardiovascular disease briefly before we move to questions?
Thank you, Dr. Nash. You know, Dr. Hargrove started the Cardiology and Medicine Clinic in 1981, and he was the first Afro-American cardiologist in the state. I joined him in 1986, and as a result of our growth and development, we became a very large practice in the city, and probably per capita, one of the largest cardiovascular practices in the city. But our mission was to focus on making sure that all Arkansans had equal access to cardiovascular care, state-of-the-art, evidence-based cardiovascular care. And so that's always been our mission. And we've done that by many ways. Just the fact that that building sits on 12th Street, you know, often we're referred to as not cardiology and medicine, but 12th Street. And we take that as a privilege and an honor because it means we're part of the community. And by that presence, we've been there as mentors for youngsters. Many people have gone to medical school and on for fellowships and distinguished careers as a result of the exposure to Dr. Hargrove. And that's been a great thing to watch that community grow. We've been present in the community in terms of not only providing direct health care, but being advocates for health care. We've been involved in various committees throughout the city, American Heart Association, American College of Cardiology, of course, the AMDPA, and many other commissions such as the Tobacco Settlement Commission. So that's part of our mission. We've also worked hard to make sure that our patients get understanding and education. So often you hear patients say, the doctor never touched me, or the doctor doesn't spend time to talk with me. And that's been one of our pillars of our mission at the Cardiology and Medicine Clinic.
Thank you, Dr. Fletcher. Thank you. And now I want to open it up to our audience. And I do have a question here that I will start with, and anyone on the panel, please feel free to chime in. The question is, the statement is, many organizations in the community are talking to residents of Little Rock about heart disease, but how can we more effectively engage the community and get them to actively change eating and smoking and exercise habits and make these things a part of everyday life? Who would like to start?
I'll address that. And actually, this is a segue to the next phase of the Spirit of the Heart. There's a program called the CHAT program. And essentially, it's a program designed to educate the community. And we're going to recruit 50 individuals who have potential contacts in the city. And we're going to have a series of modules that educate them about the various aspects of heart disease, the symptoms, the treatment, healthy lifestyles. And then of course, we're going to encourage them to go out into the community and spread the word. So that's one of the ways that we look forward to engage in the community and giving people the empowerment to go forward and have healthier lifestyles.
I'd like to jump in, Dr. Nash.
Please.
This is Kenya with the Arkansas Minority Health Commission, and thank you to the participant for that statement and question. One of the things that the Arkansas Minority Health Commission does to help with healthy eating and physical activity is that we have a program that's called Southern Ain't Fried Sundays. It is a 21-day healthy eating program plus a cookbook, and I have a copy of it here, but I'm happy to share that in the information on how you can obtain a copy of it in the chat. But what it does, we know that people's eating habits and physical activity habits do not and will not change overnight. And so we want to help them make small incremental changes that can become habits. And the way that we do that is through the utilization of our Southern Ain't Fried Sundays program. It's a 21-day program where we work with people to modify their favorite home cooked meals. You know, in the South, how we like to eat calorie dense food. Sometimes, let's just call it what it is. But in order to be heart healthy, we have to change our eating habits. And the Southern Ain't Fried Sundays program works to help you do that. So if you like macaroni and cheese, if you like sweet potato pie, go ahead and enjoy that. But do it the Southern Ain't Fried Sundays way. We have recipes to help you modify your favorite Southern comfort foods. In addition to that, we've incorporated a walking program called Walk with Ease, where we've partnered with the Arthritis Foundation. Again, we know that physical activity habits do not change overnight. And so this walking program combined with our Southern Ain't Fried Sundays program is just a small step to help everyone to live a healthier life.
So what I'm hearing is partnership and in community. Thank you. I have another question here. The participant says, I'm a founder, director of a 501c3 nonprofit organization. Our mission is to educate the communities on prevention of diabetes and management here in Arkansas. What advice would you give a nonprofit at this present season? How can we engage communities on the severity of heart disease, especially as it relates specifically to diabetes?
I'll certainly jump in there. Certainly, as you mentioned, collaboration is the key. You know, there are so many programs and organizations such as the Minority Health Commission, Association of Black Cardiologists, AMDPA, to work together with this 501(c)(3) organization. Our churches, again, the emphasis of a lot of our programs are to get the churches involved to help mobilize their membership and get involved with these programs.
Thank you. And that's that brings to mind another question. And I want to bring this to our clergy on the panel. As we know, the church has been very important all throughout the life of our community, spiritually, physically, and all the way around. So my question is for Reverend Slater. Understanding the importance of heart health, can you explain how your health ministry and other church-based activities could promote or improve health in your congregation?
Certainly, and thank you for the question. Mount Pleasant is a primarily senior congregation. I've been pastor for around 12 years. When I became pastor, we were doing a lot of activities, including walking activities, walking across Arkansas. We had members who were doing exercise classes. We had effort to change the eating habits at church socials, church anniversary meals. I think I heard someone say one of the most dangerous places you can be is at a church anniversary meal, because the food is not prepared healthy. But like Sister Eddings was talking about, it takes a while to get away from that as far as changing habits. But those are the things that we have done at Mount Pleasant, recognizing that health does not exist only in our physical health, but it is our spiritual, it is our emotional, as well as physical and social and economic. So when we look at all of the aspects of health as one or in a holistic manner, then we can readily see how we can put these things on the ground that Dr. Fletcher was talking about, because the church, particularly larger churches, have all the generations that are there, and you can see the cause and effect across generational lines in terms of the very things that we're talking about, how being healthy and how to have healthy hearts. So when you put this as part of your education ministry, and what I mean is that it is a component of Christian education. It does not replace or even come co-equal with the teaching of God's word, but it becomes a part of what we put in front of our congregation and our members all of the time. And I think it is that type of effort that it will take in order to make the differences that we're talking about. We do health fairs, we do screenings and all of that as far as partnering with others to do it. All of those things are great, but it is the education and information and the teaching of our members to access that and use what they have, in terms of the information, and learn everything I can about me and the disease that I have, how it impacts me, how it impacts my family. And then we can better, I believe, be in a position to address the heart disease issues that we're talking about here I just want to say that the co-hosts are my doctors, and they are great. And I have learned so much over the years in terms of things that I could have done when I was younger, but I can do now and live better with, in spite of the illnesses that I have. So that's, I think, where the church can come on board is your younger generation, middle generation, and the elderly who's living it right now.
Thank you. Thank you for that, Pastor. I want to ask Mr. Tolles. You know, we've heard a lot of information. We've heard a lot of data, but I say that people's voices who experience the problem are most important for us to hear from. So can you share your experience from the patient perspective, sir? What do you think is important for healthcare providers and for the community who are trying to do all these things need to know?
All right, thank you for the question. It's been my experience. I first found I had heart disease in 1991. And at that time, I had to become more structured, more consistently checking my blood pressure, checking my blood levels, if you're diabetic, A1C, working to control my cholesterol, taking my medications on a consistent day, not just, when I felt like it, but being consistent in it. Through Dr. Hargrove and Dr. Fletcher, they drilled me in that over the years to be consistent in doing all of these things, getting exercise. These are the things that they look like a lot, but once you're doing them every day, doing what you're supposed to do, keeping your weight down. If a problem occurs, don't wait till next year or next week or whatever. Go see your doctor, call your doctor, make sure he knows. Sometimes you can be a little pissed at times. You want to make sure, hey, doc, this is happening. And they would, get on it. Those are the kind of things you have to be more proactive in doing in order to maintain your heart disease. It's
so
no cure.
For patients that are in the audience, people who are experiencing problems, what I hear you saying is being more proactive in your health and with your provider. I mean, I think that's an important message. Definitely. I'm sorry, someone else?
I'd just like to make a plug for the Arkansas Minority Health Commission. We know that access can be a challenge just for basic screenings like checking one's blood glucose, checking one's cholesterol and blood pressure. Well, the Arkansas Minority Health Commission has a mobile health unit. And that mobile health unit is equipped with 2 examination rooms. We travel all 75 counties. I think Dr. Greenfield mentioned that Arkansas is mostly a rural state. And so access to quality healthcare can be a challenge sometimes, where our mobile health unit helps to fill in that gap where they exist. We provide screenings, blood pressure screenings, cholesterol screenings, and then we actually follow up with those and refer people who may have some numbers that are kind of off the chart or high. And then we follow up, to make sure that people are getting the services that they need. And so if there are those of you out in the community that are watching and would like to have the mobile health unit come to you to provide those services, please contact us, arminorityhealth.com, or give us a call at 501-686-2720. That's what we're here for.
Thank you. Thank you for that important information. Resources out in communities where they need to be is critically important. We've talked about a lot of people in communities working on these efforts, but I want to turn back for a second, back to health ministries and churches. And when Mr. Flanagan introduced himself, he talked about what he was thinking about. I want him to chime in. What is your experience with working with this in the health ministry in your space, in your experience?
Well, thank you. I've been a nurse for 23 years. I've been in ICU and the ER And I've seen the effects of uncontrolled hypertension and uncontrolled diabetes. I've seen the loss of life, the loss of function, and the loss of limb. And so Bishop Arnold and I, back in 2019, in an effort to improve the health of our congregants, developed monthly health education videos, like lasting maybe 1 or 2 minutes, that we would present at the beginning of the service. These were pre-recorded each month. And we started late in the year, so we only had September through December to work with. So each month we dealt with cardiovascular health, we dealt with strokes, prevention, we dealt with diabetes and cancer. And, I think what would have been helpful, we did have one of those months, we did have some blood pressure screenings, and I think we could have done a better job of that. And also, I think we probably could have had a healthy potluck, because I was listening to Kenya with the Southern Aid Fried initiative, and I like those ideas, and I like the idea of the mobile health unit. And I've got your number, Kenya. I want to get in touch with you to expand on that a little bit further. But each one of these videos, we just talked about various aspects of cardiovascular health, and of course, a lot of it, overlap. But and after services, I got a lot of people coming up to me asking me questions and it really showed me that people were concerned. I did get some pushback. We were talking about lifestyle changes, with the diets and changing. You got people that have been used to cooking greens and fat back. Now we're talking about doing something different. And so if somebody could, maybe come with some greens that are cooked with turkey necks, for example, just something different, and show them that it can taste just as good. But anyway, I'm glad to be here, and I'm just trying to get some information that I can take back to our church and our community and our congregants. And I appreciate you being here. Appreciate being here.
Well, I hope, and thank you for that. I hope that we make those connections in the audience also. That's one of the points.
Absolutely.
To move us to action, definitely.
Absolutely.
So I want to remind the participants, as we wind down in time, please put your questions in the chat, or I'm sorry, not in the chat, but in the question and answer section, and we will get to them as best we can. We've heard a lot of different things here. I think I want to give our panelists an opportunity. Is there something, very briefly, is there something that you think needs to be heard out there that hasn't been talked about already? I'll start with Mr. Ado.
Thank you, Dr. Nash. I think it's also important that we increase the number of African-American physicians and nurses who are underrepresented in our community. And so our ministry, Common Spirit Health, has announced a $100 million partnership with the Morehouse College of Medicine over the next decade to double the medical school size. And so we're very excited about that. And locally, we're going to be bringing some of those students to Little Rock to rotate here. So that's one piece on the physician side. And then on the nursing side, here at St. Vincent, we're going to be partnering with the University of Arkansas at Pine Bluff in helping them increase the size of their nursing program. And so those are a couple of key areas to increase representation in the healthcare community. And those are just a couple of examples of investments that we're going to be making.
As ABC has already talked about, and we all around the table have talked about this, everyone has a part to play in this, and because there's so many different factors. So thank you for that information.
May I piggyback onto that, Dr. Nash?
Yes, please.
Thank you. Just to piggyback on what Mr. Adotto said, the Arkansas Minority Health Commission also plays an integral part, a small part, in helping to train the next generation of minority healthcare workforce. We have a scholarship that we offer, $500 to part-time students and $1,000 to full-time students, full-time minority students who are pursuing careers in healthcare. So if you're interested in nursing, medical school, pharmacy, or anything like that, please reach out to us at arminorityhealth.com and we can get you the information that you need to apply.
Thank you. Thank you. Again, making connections, right? making connections, whether we're talking about access to healthcare, quality healthcare, healthcare providers, education, lots of different factors. I think everyone has a role to play. I think, Dr. Greenfield, do you have any specific ahas or takeaways?
As an OBGYN by training, having a conversation with cardiologists is definitely welcome, and having a conversation with the community is very welcome as well. One thing that people may or may not be aware of is that in the realm of women's health, when we look at maternal mortality, cardiovascular disease is one of the leading causes of maternal death as well. So I think that the importance of having conversations like this with folks who can bring good information, but also people within the community, and getting closer to the community will be very important, not just to convey the information, but to make sure that the information is actually acted upon. One point that I frequently try to make with my patients is I've been practicing medicine for about 22 years at this particular point, and I can not extend the care to the patient that without the patient being able to receive the recommendations that we ask. So I think it's very important that we do everything that we can to sort of bridge the gap between information and bridge the gap between receiving that information by the patient. So these opportunities are welcome, as Dr. Nash mentioned, making connections.
Thank you. And I'm seeing some comments in the chat that in the question and answer that I would like to bring up. One person says, I would like to see stronger efforts to educate people at younger ages about the risk factors for heart disease, for example, using social media directed toward young people. Thank you for that comment. Another one along that vein, young people under 30 are more obese at an earlier age in today's lifestyle. They're also less active, and flavored tobacco targets African-American youth. How can you more effectively reach that demographic?
Well, again, I think, as you mentioned earlier, utilizing social media in terms of areas that they frequent to kind of continue to progress that message throughout the community. And then I think just being available, I think it was mentioned earlier about more minority providers being available who sometimes can communicate a little bit better. People have more of identification. Many times you understand the nature of why people get involved in certain social habits. So I think that's very important also. And I think it underlines a very important point that we do have to learn, even as professionals and community activists and organizers, how to reach that population that currently in the past has not been reached. And as many times you can knock on the same door all the time, but the door you want to get into is the one that you've not knocked on before and gotten into. So I think that's really important. And one of the things that perhaps organizations and meetings and webinars like this brain trust can kind of help us figure out how to open those doors.
Thank you. I have another really good question, and it's a two-parter sort of. So I'm going to try this one. Is there a holistic method that can be recommended to reduce high blood pressure? If not, what's the best, what's the best pharmaceutical intervention? Amlodipine versus losartan? That's a more clinical question, but I think there's a question about holistic methods,
right,
and traditional medicine.
Well, I guess I'll swing at that one. Holistic, and we preach this all the time in the office, it's lifestyle, diet and exercise. I mean, you get out there and you know, you walk on a regular basis or whatever form of exercise you like. That minimum recommendation, 150 minutes of exercise per week. I mean, that's about as holistic as you can get. You know, you limit a lot of the fatty foods and salt-laden foods. I mean, if we look at our diet out there, everything has salt in it. And so I think we have to become more aware of what's in the foods that you're putting in your mouth. And then to answer quickly the medication part, there's no one single medicine that's best for anybody. Everybody sort of responds differently to different medications. When you look at the treatment of hypertension, you know, especially in Afro-Americans, they kind of recommend that you choose a calcium channel blocker or an angiotensin receptor 2 blocker and diuretics, low dose diuretics such as thiazide or chlorthalidone. That's sort of the mainstay. And then depending on your underlying issues, we add medications on top of that. So there's one particular medicine that is earmarked to be the best medicine. It's tailor-made to each individual.
Thank you. Wonderful, wonderful. And if there are any additional questions, please continue to put them in the chat and we will definitely get answers for you. I've heard a lot of information today. We've heard the statistics. We've heard, this is a unique atmosphere. We have policymakers, we have clinicians, we have clergy, we have clinical people, we have community-based organizations all in one spot, in this renewed focus on what we call health equity that all of us have been working on for forever. With this renewed energy, the question is then becomes, how do we move forward? I've heard policymakers, I've heard education, I've heard activities and connecting the dots to get people what they need. I now have the opportunity and really the pleasure to take us to the next part of our discussion this evening. And I have the pleasure of introducing one of my mentors, one of my colleagues, and definitely one of my friends, and that is Dr. Harold Benton. Dr. Benton is a family physician here in Little Rock, Arkansas. He received his undergraduate degree from the University of Arkansas at Fayetteville, and a Master in Science and a PhD in Biblical Studies from Trinity Theological Seminary. He attended medical school at University of Washington School of Medicine in Seattle, and he did a family practice residency at the Washington School of Medicine also. He has been in private practice since 1978, and he's an adjunct professor in the Division of Religious Studies at Arkansas Baptist College since 2005. And just from a personal perspective, Dr. Benton took time with me when I was thinking about going to medical school, when I went to medical school, and even my niece who is thinking about going to medical school. So he brings a wealth of knowledge and experience, and he walks the walk. So with that, I'd like to pitch to Dr. Benton.
Thank you, Chriselle, for that wonderful introduction. This has been an absolutely wonderful webinar. The issue now is the call to action. I've been taking notes since we've been going on, and the first one I want to do is a discussion of digital literacy. One thing COVID-19 taught us with telemedicine and all of that is that some members of our community are not that literate. And so I'll want to ask from any panelists, particularly those who are pastors, how we can better educate our members, the elderly people and others about digital literacy so they can participate in some of the things that's necessary. Pastor Slater?
Yes, thank you. I will answer that for Mount Pleasant. Basically, we went digital with our worship services within a couple of months after COVID hit, and we did it virtually for 3 years almost. And we went back into our sanctuary in February of this year. And when we first started, a lot of people did not have access to computers and Wi-Fi and that sort of thing in terms of being able to access it. So what we did, we just kind of made it available. And it's not a hard sell for people that really want to do it, but for people that are afraid of it, it is a hard sell. And I think what we wound up having to do is actually just take it to people, in terms of getting laptops and that sort of thing. Right now, I believe that most of our members, am I muted?
No, sir, go ahead.
I believe most of our members have access. So the thing is to take it to them, particularly those who are afraid or intimidated by it.
Okay. From the standpoint of telemedicine physicians on the panel, is there anything else we need to do to have that better accessible to our people in our communities?
Well, I think the first part about that, Dr. Benton, is that telemedicine is here to stay. It's an adjunct to our current visits. And I think as time has gone on, patients begin to appreciate telemedicine and they're less fearful of it and they see the benefit of it. So I think we just need to continue to encourage people that it's not a substitute for the office visit, but it's an adjunct to the office visit to enhance the doctor-patient relationship. And then continue to work with our government officials for funding and access, and to be sure that internet and Wi-Fi access is available to all parts of our community.
Very good. Chad Aduttle brought about the wonderful things they're doing with St. Vincent Hospital as it relates to engaging the community, and it opens up another action, and that is remote monitoring. And that is to say, we have many insurance companies, particularly the Medicare Advantage insurance, that will allow patients to purchase supplies and things. But what can we do in a point of action in talking to these insurance companies into allowing their members to get blood pressure cuffs and other kind of things where they can monitor themselves? That's a governmental question. I know it's legislative, but I think it's worthwhile from a policy standpoint to even look at that as a point of action.
So from my perspective, we're having conversations with the payers and with the government officials related to reimbursement right now in the state of the healthcare industry. And the reality is our current healthcare industry is unsustainable. It's too expensive. It doesn't provide the outcomes that we need. It doesn't provide the access that we need. It's not equitable. And so there's changes that needed to be made. And it's interesting that some of the fixes to the high cost of healthcare are to do things like you're suggesting and increase access to remote monitoring, to increase access and payment for telemedicine. So it's trying to do things that keep people out of the most expensive setting, which is the hospital. And so fortunately in healthcare, the payers and the government are beginning to converse with the providers about a focus on quality and access and preventative medicine, and less on inpatient and hospital care, because that's what's costing us so much right now. And so again, more focus with the payers, with the government, putting more dollars into preventative and quality and access, and it's really going to improve access for the entire community to the system, and it'll be less expensive.
Good. Another
And
point of
Dr.
action.
Ben,
Yes, please.
Ben, I just like to add, from a payer perspective, those discussions are going on. As Dr. Fletcher said, telemedicine is not going away. So to make sure that our communities have access to it, we have to make sure that doctors who disproportionately see people of color have access to the equipment and resources that they need to have it, all the way up to broadband. And those discussions are going on right now. And we just need to make sure that we have advocates inside and outside the system to continue to push that with a health equity framework.
And that's good, because the other part we heard tonight is the role of youth in church and social media. They're certainly correct. I see a lot of children obese, many are diabetic, and so an intervention is necessary. So to my clergy and others in the audience, we know about the effect of inappropriate eating on our adults, but I don't think we spend a lot of time with our children. Am I correct? And how can we handle that in the youth ministry at churches?
I believe education is going to be the best thing as far as impacting the students that are at church, and what that's going to take is a commitment of resources. Basically, we're talking about education and making that an integral part of what we teach, looking at health holistically. And I think that is a way of impacting that, is by bringing it on board as far as being a part of the things that we teach on a routine basis, not just on a once or twice a year type thing.
Mm-hmm. Mm-hmm.
Dr. Benton, if I may also interject, I think it's also important that we as a community and our church-based foundation of that community enhance their exposure to exercise and make safe facilities available for them to exercise on a regular basis. I think that's one of the largest components of our obesity epidemic.
Very good, because every segment of our community needs a plan of action. And one segment can't necessarily depend upon the other to do all the work. It takes all of us to do it. Yes, it does take a village. This is a church and a medical village. Now, The other part would be the role of government. And we know that our governor has talked about increasing broadband accessibility across the state. What kind of things can we do to identify and implement changes to help our communities across the state? That's to reduce healthcare disparities, looking at the social determinants of health and modifying that. That's a big question. I know it is.
Dr. Patton, I think one of the things we need to do is to advocate our most powerful weapon, and that's voting. We have to mobilize our community to get out and vote and look at the issues that are germane to our constituents and our families and vote along those lines.
Okay.
Can I add, Dr. Benton,
Yes.
that after we vote, which is critical, if we vote to get broadband, we have to make sure that those resources go to the areas that are most in need. Sometimes, oftentimes, it does not. So I think it's incumbent upon all of us to be advocates.
Okay. To Chad Duddle, I was so impressed at the kiosks that you have across the city, perhaps across the state for your blood pressures. May I suggest or request that that those locations be made known to more people? I love to tell the members of my church, for an example, about that. There are other programs that we have that if we were to share one with another would also help our community. What do you think, Chad?
Absolutely. We want to expand those kiosks. Again, we have them at the malls currently at Park Plaza Mall and McCain Mall. But I'd also say for all the congregations, the clergy, the pastors listening tonight, we're already partnering with a couple of churches to do free blood pressure screenings, as well as provide access to our Heart Smart preventative program. And again, you've talked about it. Talks about it takes partnerships. It takes a village. We're happy to partner with more churches to do those blood pressure screenings, and again to try to increase awareness, increase education. So I'm going to put my colleague on the spot here. You can reach out to Bonnie.Ward, W-A-R-D, Bonnie, B-O-N-N-I-E .Ward, W-A-R-D @commonspirit.org. If your church is interested in having us come and do those blood pressure screenings and introduce the Heart Smart program. And so again, whether it's getting the blood pressure screenings at the kiosk or partnering with a church, we just want to partner with you all to try and increase that awareness and increase that access.
Very good.
And Harold, if I may add, there's already been discussion along those lines of enhancing the availability of those kiosks and even looking at smaller versions that would be perhaps available for churches and entities like that.
Okay. And then Kenya with the Minority Health Commission. Yes, I've enjoyed your Southern Ain't, what is it?
Southern Ain't Fried Sundays.
Southern Ain't Fried Sunday.
Yes.
That really racks the brain of most of us Southerners because we're used to Southern is Fried Sunday. But all laughter and such put aside, does the Minority Health Commission likewise go out to other community organizations, churches, social clubs and such and spread this message?
Absolutely. We're everywhere. We are a small but mighty team. And just to piggyback or to extend the conversation a little bit further about Southern Ain't Fried Sundays, we've been going out here lately since COVID restrictions have kind of backed up a little bit. We've been going out meeting with community organizations and actually demonstrating how to prepare a couple of the recipes from the book. And I know that someone mentioned about greens with the turkey necks and the fat back. Well, we have a recipe for that. There's a recipe in our Southern Ain't Fried Sundays cookbook that talks just about greens and how to prepare them in a healthy way. A lot of times people think that healthy food does not taste good, but we're here to tell you and to show you that healthy food can taste good, particularly when it comes to Southern Ain't Fried Sundays meals that are found in our cookbook. And so we're happy to partner with any organization out there that wants to have us.
Thank you. This is Dr. Edward Ivey, the Director of for community programs for ABC. Could you give us a summary of the activities that the ABC is doing to help communities address cardiovascular health?
Definitely. And thank you so much for this introduction, Dr. Betton. So the Association of Black Cardiologists is working with communities like the Little Rock, Arkansas community to try to spread the word about improving heart health. This Spirit of the Heart program is our signature program to really bring awareness to the fact that cardiovascular disease needs to be addressed and to really try to convene those stakeholders in the community that can take efforts towards improving cardiovascular health within Little Rock. But we also offer our Community Health Advocate Training Program. This program is a program that allows lay health individuals in the community to be trained using the With Every Heartbeat is Life Community Health Worker Manual developed by the National Heart, Lung, and Blood Institute. And we teach those lay health individuals not only how to follow the sections within the manual, but also looking broader that our cardiologists are able to create and develop so that we can get the message out to the community. In addition to our community programs, the Association of Black Cardiologists, which is a network of cardiologists throughout the whole country and throughout the world, try to make efforts to improve health through research, through advocacy with our Women and Children's Committee and with many other community programs as well. So thank you for introducing that. I will ask that we go to the next slide. We do have a slide about some of the programs that we are conducting. One of the programs that we are conducting is our Spirit of the Heart Gala, which is coming up. I do encourage everyone to visit our website, abcardio.org, to learn more about our events. You can see on the screen now about our Health Equity in Motion Spirit of the Heart Gala. And so there are many activities that are going on. I will want to thank everyone. This video, this program is being recorded, and you will be able to see the recording on our website. So thank you all, and I would like to right now turn it over to Dr. Hargrove for our closing.
Thanks very much, Dr. Ivy. We've had a wonderful discussion tonight about the health of the people of Little Rock and the importance of finding ways to stay healthy. We want all our children to have the ability to know their grandparents. But to do this, the grandparents have to live long lives and in order to have a relationship with their children. Unfortunately, too many of our adult African-American men and women are dying at a young age. And the problem is not getting better, it's getting worse. President Barack Obama once said, "The change will not come if you wait for other person or other time. We are the ones that we are waiting for. We are the change that we seek." As we leave here tonight, let us think about how we can change our community. Let us consider how we can make the change now. Thank you, everyone, for joining us tonight in this important discussion. And I would like to thank all of our presenters, including Dr. Greenfield and Dr. Fletcher, for sharing with us the burden of heart disease in our beloved city of Little Rock. I would like to thank the panel. Your organizations are doing wonderful jobs in making Little Rock stronger. I would like to give a special thanks to the Association of Black Cardiologists for having brought this exciting program to the city of Little Rock. And we hope this is not the last one. Thank you very much and good evening.